La Universidad Libre de Berlín, pues constituye una de las principales referencias internacionales para la investigación de las bases neurobiológicas del lenguaje. Entre las líneas teóricas y experimentales de este centro de investigación se encuentran modelación neurocomputacional basada en el cerebro, neurofonología, neurocombinatoria, neurosemántica, neuropragmática y neurorehabilitación del lenguaje. Su gran artífice y actual director, el profesor Müller, desgraciadamente no puede estar hoy con nosotros, es una de las personalidades más influyentes en la neurociencia del lenguaje. Es bien conocido por su modelo del procesamiento lingüístico o de la web funcional, basado en la actividad de circuitos neuronales vinculados con la percepción y la acción. Profesor de Neurociencia del Lenguaje y Pragmática del Departamento de Filosofía y Humanidades de la Universidad Libre de Berlín, entre su actividad previa figura la dirección de la Unidad de Cognición y Cerebro y del Programa de Neurociencia Cognitiva del Lenguaje de la Universidad de Cambridge entre los años 2000 y 2011. Ha sido, además, profesor en numerosas universidades alemanas, como Tübingen, entre otras, y visitante en una decena de universidades internacionales, promotor de numerosos proyectos de investigación y miembro de destacadas instituciones y sociedades científicas y de comités editoriales de revistas de primer nivel. Entre sus libros quiero resaltar The Neuroscience of Language on Brain Circuits of Words and Serial Order, publicado en la Cambridge University Press, libro de cabecera para muchos de nosotros. He contabilizado al menos 242 artículos en revistas tan conocidas como Cortex, Brain and Language, Biolinguistics, etc., y más de 50 contribuciones en volúmenes muy prestigiosos. Entre las más recientes contribuciones de su equipo destaca un nuevo método para el tratamiento intensivo de la afasia. Una de sus principales colaboradoras es precisamente la profesora Lea Doppelbauer, que hoy nos acompaña. Pues, además de su formación científica en el ámbito de la neurociencia del lenguaje, debo señalar su faceta como terapeuta, que ha permitido profundizar en la neurorehabilitación, especialmente en el caso de las afasias. De los resultados alcanzados en esta nueva línea, no les voy a desvelar nada, pues ella en su intervención nos va a contar de qué se trata. El título de su intervención es Language, Action and Neurorehabilitation, Which Factors Determine the Success of Speech-Language Therapy. You are very welcome. I give you the floor.
Do you hear me? Yeah. Thank you for this introduction. Yeah, it's a pleasure for me to be here today and speak to you in the name of Friedemann Pulvermüller. He sends greetings, of course, and a few words to me. So I'm Lea Doppelbauer, and I have a bachelor's degree in speech and language therapy, so clinical linguistics, and I have a master's degree in mind and brain sciences, and now I am doing my PhD in the group of Professor Pulvermüller in the Brain Language Lab in Berlin. So. This is what I'm going to talk about today, so I will give a brief introduction into the topic. We'll then talk about two features that might determine the success or contribute to the success of aphasia therapy, and we'll end with some translational considerations and present some preliminary data on long-term effects and a little more. So, aphasia, I think most of you might know this. Aphasia is an acquired language impairment caused by focal brain damage, which is typically occurring in the pericerian language cortex in the left hemisphere, which is highlighted here in this graph. And aphasia is a multimodal language deficit, so most often comprises language production, language comprehension, reading and writing abilities. And as you can see in these incidence and prevalence rates, it's a quite common disorder following stroke. So since it is that common, there is need for help for those patients, but the question is aphasia therapy efficient for those patients? And there is agreement now that at acute and subacute stages, so quite short after the stroke has happened, it is beneficial for the patients to deliver and administer some speech and language therapy. However, the opinions diverge whether aphasia therapy is still efficient after some while, so in the chronic stage of aphasia, 6 to 12 months post-disease, post-aphasia onset. So, since this is the case, it is very essential to determine factors that contribute to the success of speech and language therapy, even at the chronic stage, so even months, years after the stroke has happened. And there are a lot of methods available for speech and language therapy, so typical exercises in conventional behavioral speech and language therapy are naming and describing picture exercises, matching words or even sentences to pictures, completing sentences and completing words, finding synonyms or semantic categorization tasks. So in every linguistic discipline there are tasks, exercises available for aphasia therapy. The setting is usually that there's one patient and one therapist, and so one-to-one setting, and usually therapy is delivered for 1 hour a week, ideally 2 to 3 hours a week. So in behavioral speech and language therapy, words and sentences are typically used out of everyday communication, namely in exercises like naming or describing pictures. So question would be, what is this called? Would be the task then in therapy. However, we typically use language in the context of interactions and social interactions. For instance, asking someone for something and then receiving it. Therefore, it was claimed in the philosophy of language, for instance by Wittgenstein, that language is woven into action, so that we use linguistic forms like words and sentences and signs as a tool for communicating in everyday life. And he illustrated this by his concept of language games, which describes some type of interaction in which language is a part of the action. For instance, instructing someone to hand over things and then to build out of these things handed over. Then the words are used and are part of the language in instructing and in the action itself. So, and indeed we find these language action links in the brain. So the left peripheral language cortex, which you can see here in bluish and greenish colors, is structurally and functionally interwoven with the brain's action system, which you can see here in pink and violet colors. And when we use modern techniques like trajectories, so tracking fiber bundles in the brain, we can indeed find that there is a pronounced connection between the language and the action systems in the brain here. And this connection is much more pronounced in humans than it is in monkeys, which lack the ability to communicate as we humans do. And furthermore, we find not only this structural connection, but we find also functional interaction between language and action systems. For instance, in fMRI studies, so studies using functional magnetic resonance imaging, it was found that this functional interaction is quite semantic. So when people hear or passively read action-related words like kick, for instance, then in the action system of the brain, in the motor cortex, those regions become active that are actually involved in doing the action of kind of kicking a ball or something. So the same areas are lighting up when we passively read or hear action-related words. And we find that this activation from the language cortex to the motor cortex happens very, very, very rapidly. So this was shown in MEG and EEG studies. And furthermore, we find that this functional interaction we find kind of reflects true semantics, because it was found that there are correlates of semantic priming in the motor cortex when priming for action-related words in the brain. So and furthermore, we find that it might even be that the motor cortex is causally involved in processing language. For instance, here in this study, there was a patient who had very focal lesion in the motor cortex. So the motor cortex was impaired, and this patient showed a category-specific deficit in processing action-related tool words, whereas all other word categories, processing food words, animal words, were not impaired. They were intact. The only thing that was impaired was the processing of action-related tool words. So it might be that the motor cortex is necessary for processing those kind of word types. So there is a link between language and action, which is manifest at the biological level. So the question is, can we use this for the clinical context? Could concordant activation of the language and the action systems in the brain facilitate language processing in aphasia? And might action embedding of language be a relevant factor for aphasia therapy? So what is this action embedding? Well, we can use the same utterance for different purposes, for naming, for instance, or for requesting. An example is the utterance water can be the answer to the question, what is this called? Or it can be the answer to the question, what do you want? In the first context, the word is used in the context of an exercise, the exercise of naming the thing that is depicted there. And in the second case, the word is used to reach a communicative goal, namely to reach the goal of, to request a glass of water. So the word water is embedded into the action of requesting. And the question is, does it make a difference to the brain whether we use words in the context of naming or in the context of requesting, for instance? And it does make a difference. So in this study, it was found that it was tested, so participants used words, the same words, in the context of naming or in the context of requesting. And it was found that the brain activity that was measured was much more pronounced when the people used the word in the requesting context, which was found here, which is shown here in the EEG study. So the red line is the brain activity for the requesting context. So there's more brain activity when we use words in the requesting context than using it in the mere naming of things. And it was also found that in this brain activity that we see when we request things. This is not only in the language areas, but this activity is also found in the motor cortex, so in the action system. This is also active when we request things, which is not the case in the naming context. So there appears to be more pronounced brain activity, so the brain is more active when we use words in this action-embedded requesting context. And therefore, recent treatment approaches for aphasia implement this language training in the context of social communicative actions and interactions. And one approach is the constraint-induced aphasia therapy, or it's an extended version, the intensive language action therapy. So these two names kind of refer to the same concept, but the latter one, the ELAT therapy, includes more extended methods and a more extended version. Yeah, what is this kind of therapy approach? There are three principles, and the first principle is that is the mass practice principle. So therapy is delivered with high intensity. The second principle is the embedding of language in action context, as I just introduced you. And the third principle is constraining the patients to avoid learned non-use. So guide the patients to focus on specific linguistic and language targets, to focus on verbal communication. I will talk about these principles in more details now. But first, the entire setting. So there are 3 to 4 patients and a therapist in this treatment. They are seated around a table, and the patients and the therapist take turns in passing picture cards, on verbal request. And the picture cards that are used, they suggest to use verbal utterances, verbal communication, and this verbal communication is encouraged in the patients, and non-verbal communication is not encouraged. But this does not mean that gestures are forbidden. So gestures, of course, as we do in natural communication and natural language, can be used to support verbal communication, but not to replace it. So now in more detail, the 3 principles. So the high therapy frequency principle. Therapy is delivered within a very short amount of time, so within 10 days, with a high daily amount of therapy. So 30 hours of training within 10 days, as compared to what is delivered conventionally, namely 1 to 2 hours a week, distributed over a much longer period of time. Focusing and constraining language means that the patients are guided to use specific utterances and communicative features which are individually tailored to the patient's needs and capacities. So we can adjust how the patients should verbally request, really tailored to what the patients, to their aphasia severity, and also to their remaining language skills. The action embedding. So this is how is this implemented in this therapy approach? This is kind of an abstract thing. So how is it implemented? By means of language games, as it was proposed by Wittgenstein. So patients should obtain picture cards by verbal requests. And we use object picture cards or action picture cards, for instance. And then within these language games, the communication is similar to how we communicate in everyday life. So this is a communicative sequence we know from everyday life. For instance, patient A makes a request, please give me the water. Patient B then can follow the request in case the picture card is available. Here you are, the glass of water. Or it can reject the request in case the picture card is not available. So, no, sorry, I don't have a glass of water. Or he can clarify the request in case there was a misunderstanding. For instance, sorry, what do you want? Something to drink or so? So this is a communicative action sequence that that is similar to what we do in everyday life. Of course, simplified, sure, but similar. Yeah, and I brought a video to show you how this looks like. And there's an English subtitle here.
Ich möchte. Nein. Ich möchte. Nein, aber. Ich möchte. Wasser.
Ich habe Angebote. Und zwar eine Kanne.
Nein.
Nein. Und einen. Tja. Giraffe.
Nein.
Nein? Dann habe ich rechts.
Genau. Ich möchte. Nein. Ich möchte.
Wasser oder Wasser, nicht Quatsch, wie heißt das, Kanne oder Papa Giraffe.
Nein, ich habe keine Waffe.
Okay, Sie wollen keine Giraffe.
Genau.
Und fragen Sie mal weiter, würde ich sagen.
Ich möchte. Nein, aber. Ich möchte. Ja, ich möchte Wasser. Ja, aber
Ich glaube, Glas.
Glas, ja.
Ja?
Ja.
Dankeschön.
Ah, genau.
Ja.
Super.
Yeah, I think this was a little delayed, but I hope you got. So, this is how the treatment looks like, so how the language games are implemented in a therapy setting. And of course, the important question is this treatment approach efficient or not? And in 2001, a randomized control trial was conducted, so a clinical study. And this clinical study compared the ELAD or SIA therapy with a standard behavioral speech and language therapy. 17 patients were included in this trial. They suffered from chronic post-stroke aphasia, so they were more than 1 year after their aphasia onset. Patients were randomly assigned to two groups. The first group received SIAD or ELAD therapy, just as you have seen in the video and as I described it, and they received roughly 30 hours of training within 2 weeks. The second treatment group received conventional behavioral speech and language therapy. They received the same amount of therapy, so again, roughly 30 hours, but in a distributed manner over 4 to 5 weeks. There was an assessment of language functions conducted before and after the treatment, and we used the standard aphasia test battery for the German language, the Aachen aphasia test, and the communicative activity log, which is a questionnaire in which the relatives have to rate the communicative activity of the patients in everyday life. What was found was that there was a significant improvement in language test scores on the aphasia test battery after the ELAD and CIAD therapy, which was not found for the conventional behavioral therapy. However, the groups did not only differ in their methods that was delivered in therapy, but they did also differ in their intensity. So in the one group, therapy was delivered intensively. In the other group, it was delivered in a distributed manner. So we still don't know whether the language action embedding context, which was the question, whether this is contributing significantly to these improvements. And therefore, another randomized control trial was conducted in 2016. This was published. And again, ELAD and CIAD was compared to a conventional naming therapy in a crossover design, which means that each patient received both kinds of therapies. And 18 patients participated here. They were, again, chronic non-fluent aphasia patients, more than 1 year post-onset. This time, critically, the features of the therapies were kept constant across the methods. So same intensity, same duration of therapy, and the same materials were used. What was different was the degree of action embedding. So the degree of whether they had to request things or whether they had to name things. This is again this crossover design, and we again used the Aachen aphasia test and the communicative activity log to assess language functions. What we found was that there was a consistent improvement of language functions after the ELAD and CIAD therapy, which was not the case for the control, the naming therapy. This also led to some improvements, as you can see here, but only if this therapy was delivered as the first therapy. So after this trial, since everything else was kept constant in this study, we could conclude that language embedding might contribute significantly to the success of aphasia therapy. However, these were only 18 patients, so you have to keep this in mind. But still, these were kind of striking results. So what now does the high therapy frequency play? What role does this play, since we have seen that this might contribute to therapy as well? So the question is, when we ask, does aphasia therapy help, what role does the intensity play? And there was one early study published in 1982 that found, so this study concentrated on acute aphasia with a high N, so a lot of patients were included in the study, and it was found that the therapy that was delivered in a non-intensive way did not lead to a better outcome than no therapy. So the conclusion from this study was, well, aphasia therapy doesn't help at all. However, years later, there was conducted a meta-analysis about across a lot of studies published, and it was found that aphasia therapy is efficient if it is delivered a minimum of 5 hours of training a week, so intensively. So 5 hours of training appear to be necessary for the success of aphasia therapy. And this was then confirmed recently in another important review, the Cochrane review, that showed that high-intensive speech and language therapy is much more efficient than low-intensive therapy. And another big study with 150 patients was conducted in Germany recently, and they also found that compared intensive therapy to no therapy, and they found significant improvements after intensive therapy, but not after no therapy. So intensity seems to play a role, and there is kind of a threshold, or it was suggested that there might be a threshold of 5 hours of training a week that is very important for aphasia therapy. So it was, we conducted another trial to investigate how intensive should it be? So is it important to be more than 5 hours of training a week or even more? So we compared highly versus moderately intensive language therapy, and this was ELAT therapy. And patients received ELAT for 2 and for 4 weeks, and 30 patients were included, again, chronic post-stroke aphasia patients. So this is the design. Patients received either 6 hours of training a week or 12 hours of training a week. So moderate intensity versus high intensity. And there were 2 training intervals, each lasted 2 weeks, so in total 4 weeks of training. Testing was done at each of these time points, again with the standard test battery and the Aachen aphasia test and the communicative activity log. What was found was that intensive therapy in both groups, which were both above 5 hours of training a week, was efficient in these patients. So both groups showed a significant rise in their language abilities as measured in the test battery. But there was no difference whether therapy was delivered at high intensive frequency or at moderate intensive therapy. But what made a difference was to extend the therapy, the therapy period. So 2 weeks, and then adding 2 more weeks led to better outcomes. So what can we conclude about the role of intensity in the efficacy of speech and language therapy? So there appears to be a threshold for the efficacy of speech and language therapy, which is a minimum of 5 hours of training a week, which appears to be crucial for the success of therapy. Increasing the therapy further appears not to be that significant, so does not lead to, does not deliver an added value to therapy success. However, increasing the duration is an added value. So increasing the therapy duration of intensive treatment approaches significantly increases benefits. So we now know that, or we can conclude from these data that the high frequency therapy principle and the language embedding principle contribute to the success of ELAT therapy. So what about this third principle, the constraining or focusing of language? I'm not going to talk about this in much detail, and because there is not that much data available now, but this as a discussion point. So there was a study published in 2016 which showed that the third feature, so the focusing or constraining patients on verbal utterances, may not be that crucial for the success of ELAT. This study compared ELAT therapy with another treatment approach which is called PACE, in which patients are allowed to freely choose their modality of communicating. So they can use verbal utterances, or they can use gestures, or they can write to communicate. So they compared these two treatment approaches, and they found that there was no difference between the groups, no significant difference between the groups. So the conclusion was it might be not that crucial to focus patients on verbal communication. However, these treatment approaches in this study were not kept that different from one another as they actually are. So the therapy settings were the same in both treatment groups, so which is originally not the case in the PACE study, in the PACE approach. So we need more research to conclude whether this third principle is contributing to the success or not. We don't know yet in that detail. So we know that ELAT and TIA therapy is and other intensive therapies have an effect on chronic aphasia, but we don't know whether how their impact is on acute and subacute stages. So we don't know what these language embedding and the intensity, how much this contributes to the success in acute and subacute stages of aphasia therapy. What we can conclude is embedding linguistic utterances in interactions, in communicative interaction, appears to improve therapy outcomes. There is convergent evidence also from neuroimaging studies that action embedding boosts brain activity, which might be the explanation for why this is a building block that contributes to the success of aphasia therapy. And aphasia therapy works even at the chronic stage if it is delivered intensively. So as a threshold, 5 hours of training a week. Further enhancing this therapy frequency from moderately to highly intensive practice does not seem to be very a significant contribution to success, but prolonging the intensive therapy interval seems to be beneficial for the patients. Now, research has shown speech and language therapy works if it is intensive and if it is action embedded. So there might be other features, but for these two features there is evidence that shows it is, it helps. This then means, or would have the implication that standard speech and language therapy that is given in most countries is not efficient because it's not intensive and it's not action embedded. So an alternative and more efficient way and even more cost neutral therapy application would be to deliver intensive therapy given for short intervals and then give it repeatedly. However, this requires some more knowledge about it, namely that therapy effects, even if delivered in such a short interval, are stable a long time after this intensive therapy interval, and that an additional, so another application of an intensive interval still leads to a better to progress in speech and language abilities in those patients. And we are working on this and working on new data to find some answers to these questions. And I will present some preliminary results from a study we are currently, which is currently in preparation. In this study, we investigated 32 patients, again with chronic aphasia, and then they took part in 2 to 4 weeks of intensive speech and language therapy. So intensive ELAT was delivered to them, and we invited them to a follow-up investigation 1 to 2 years after the intensive therapy to check whether their gains in language functions are still present 1 or 2 years after it. And what we found is very nice, because we find that they are in this population of this sample of 32 patients, the therapy effects were preserved over 1 or 2 years after intensive treatment, which is very nice. So these data here at follow-up are still significantly different from those at baseline, so before therapy. But we found an interaction with age, which means that in younger patients, the gains in language functioning after intensive treatment seem to be better preserved than in the older population, in the older patients. However, there are also a few cases, a few old patients above 70 years, which, in which the language functions were preserved and they still improved further in the follow-up interval. We also currently look at data for a double application of ELAT therapy. Here we have a very small sample with 11 patients that participate in ELAT twice. And we look at, there was an intertherapy interval of 8 to 24 months, and we find that that even this second treatment interval of ELAT leads to more gains in language functions, even above the level of the first interval. So it might be a good alternative, preliminary of course, to deliver ELAT twice. So we are working on this, and you may read about it. Now I want to thank the ELAT team, and I want to thank you for the attention.
Thank you very much for your presentation. Now we have a little time for questions. Any questions? I wanted to ask you about the key. What's the key? The key is the word or context, because you're talking about actions and actions in context. So maybe the key is not the word; it's the context in which.
Exactly. The key is the embedding of the language as it is originally used. So as we all use it every day, we are not walking around and say this is a table, this is a chair, this is a glass of water. We use words embedded in the actions we do. So this is the idea behind it.
More questions? Okay, so levantamos la sesión. Nos vemos a las 4:30.